categorized by two clinical scenario. Number one, acute heart failure. Number two, chronic heart failure. Acute heart failure may occur in three subsets. Number one, in a normal heart. Number two, in a setting of pre-existing or chronic heart failure. So, evaluation of acute heart failure should be focused today. Now, first, I want to assess the clinical scenario before going to elaborate discussion through my slides. A patient presenting with the features of heart failure or suspicious features of heart failure, one should assess the clinical profile of the patient. Number one, we should start from the general appearance of the subject, like faces, like presence or absence of lower limb edema, and with a focused history in the form of dyspnea and other subtypes like paroxysmal nocturnal dyspnea, orthopnea, etc., as well as features of hypoperfusion. Now, what would be the clinical assessment? Number one, first, the capillary refill or peripheral hypoperfusion or chronic hypoperfusion that is reflected by certain clinical parameters. Then we should search for presence or absence of systemic or chronic congestion. So assessment of acute heart failure should be focused on two clinical aspects. Number one, assessment of chronic hypoperfusion as well as assessment of chronic congestion. In the previous class, I have discussed in a chart how do we assess. Now, at present, the point is a clinical assessment. First, we should search for the symptoms, focused symptoms of the heart diseases. Elaborately যাচ্ছি না, ওটা ক্লিনিক্যাল ক্লাসে পড়ানো হবে। সেকেন্ড হচ্ছে ক্লিনিক্যাল এক্সাম, ক্যাপিলারি রিফিল। নাম্বার টু, hand. Number one, dry and warm, or dry and wet, or wet and warm, or wet and cool. In the previous slide, congestion at rest symptomatology and signs includes orthopnea, elevated jugular venous pressure, pulmonary crepitations, rals, S3 gallop, and presence or absence of edema. On the other hand, low perfusion at rest is characterized by narrow pulse pressure, cool extremities, and hypotension. So, congestion at rest, no, অর্থাৎ কোনো কনজেশনের এভিডেন্স নেই, তাহলে হাতের অবস্থা হবে ওয়ার্ম অ্যান্ড ড্রাই। আছে, তাহলে হাতের অবস্থান হবে ওয়ার্ম অ্যান্ড ওয়েট। অর্থাৎ ওয়ার্ম অ্যান্ড ড্রাই a reflection of is no reflection of congestion at rest, whereas warm and wet is a reflection of presence of the suspicion of congestion at rest. Second, Low perfusion, no. Situation of the hand is warm and dry. Yes, cool and dry. অর্থাৎ লো পারফিউশনের রেস্ট ক্লিনিক্যাল কো প্যারামিটার বা কো ফ্রেন্ড বলা যেতে পারে। Warm and dry means absence of low perfusion at rest, and cool and dry means presence of the low perfusion at rest. And when both congestion at rest and low perfusion at rest coexist, then the situation of the hand is cool and wet. So, from the beginning, number one, capillary refill, number two, status of the hand, number three, pulse pressure or pulse volume, number four, blood pressure, number five, pulse pressure by means of assessment of the BP. Fifth, elevation of the jugular venous pressure, jugular venous extension. Sixth, presence of the bronchi and crepes at the lung bases. And the last, S3 gallop and intensity of S1 or S2. So summarizing the feature, last but not the least, presence or absence of edema. So summarizing the clinical profile by bedside assessment indicates includes number one, capillary refill, number two, status of the hand, number three, pulse volume, number four, pulse pressure, number five, truncated systolic BP, number six, jugular venous distension, number seven, bronchi and crepes at the lung bases, number eight, intensity of first sounds that may be diminished, as well as presence or absence of S3 or S4, mainly S3. S4 is only present in a setting of diastolic dysfunction or heart failure at risk with evidence of LVH, left ventricular hypertrophy. From clinical assessment, we can assume the patient having the degree of pulmonary capillary wedge pressure or the assessment of cardiac index. ইকোকার্ডিওগ্রাফি ছাড়াও আমরা বেডসাইড অ্যাসেসমেন্ট করতে পারি, যদিও সেটা অ্যাপ্রক্সিমেশন অ্যাকিউরেসি থাকে না, তাহলেও ইকোকার্ডিওগ্রাফি ছাড়াও আমরা যেহেতু রুরাল বেল্টে মফস্বলে কি বলবো ক্লিনিক্স নিয়ে মাথা ঘামাচ্ছি, সেটা আমরা প্রথমেই মাথায় রাখতে হবে যে আমরা বেডসাইডে একটা পেশেন্টের হার্ট ফেলিওর আছে কিনা, তার পিসে ডাব্লিউপি কত আছে, তার কার্ডিয়াক ইন্ডেক্স কত হতে পারে, এই রাফ আইডিয়া কিন্তু বেডসাইডেই পাওয়া যেতে পারে। ফর এক্সাম্পল, ক্লাস 1 নর্মাল, অর্থাৎ নো ক্রনিক কনজেশন, নো ক্রনিক hypoperfusion, তাহলে estimation of the PCWP definitely less than equal to 18 millimeter of mercury. Cardiac index more than 2.2. What is the normal values of the cardiac index? 2.6 to 4.6, এটা ভ্যারি করে, কেউ বলে 2.8 to 4.5, কিন্তু রাফলি 2.6 to 4.6 is the normal variation of cardiac index. What is cardiac index? জোরে জোরে শুনতে পাচ্ছি না। Definitely, what is the definition of cardiac index? Stroke volume per minute per square meter of the body surface area. Normal values are already mentioned, 2.6 to 4.6. ঠিক আছে? So at the bedside assessment, we can assess the normal, that means no systemic congestion, sorry, no, হ্যাঁ, একটু এলোপাতাড়ি হয়ে যাচ্ছে গরমের জন্য। একটা কথা জিজ্ঞাসা করে নিচ্ছি, শোনা যাচ্ছে কি? আচ্ছা, সুতরাং নো chronic congestion, no systemic hypoperfusion. That means PCWP definitely less than 18 or cardiac index less more than 2.2. Number two, pulmonary congestion. Clinical parameters of pulmonary congestion, symptoms in the form of dyspnea and exertion, paroxysmal nocturnal dyspnea, orthopnea. S3 gallop, pulmonary rales, S3 gallop, pulmonary crepitations or rancor. So presence of the pulmonary congestion means elevation of the PCWP, অর্থাৎ pulmonary capillary wedge pressure exceeding 18 millimeter of mercury. But in absence of low output or low perfusion, cardiac index definitely more than 2.2. থার্ড ক্যাটাগরিতে যেখানে বলছি যে কোনো কনজেশন নেই, অর্থাৎ নো ক্রনিক কনজেশন, কিন্তু সিস্টেমিক হাইপোপারফিউশন আছে, এগুলো সব ক্লিনিক্যাল প্যারামিটারে কিন্তু অ্যাসেস করেছি। সেক্ষেত্রে পরিষ্কার কথা, আগেই বলেছি কনজেশন নেই মিনস পিসিডব্লিউপি ডেফিনেটলি লেস দেন 18 and cardiac index definitely less than 2.2. এখানেও রিপিট করছি যে কনজেশন অ্যাট রেস্ট বা হাইপোপারফিউশন অ্যাট রেস্ট, তার ইন্ডিকেশন কি ক্যাপিলারি রিফিল থেকে শুরু করে পরপর পয়েন্টসগুলো বলে গেছে। সুতরাং কনজেশন অ্যাট রেস্ট আছে, বারবার ভুলে যাচ্ছে, বলছি হাইপোপারফিউশন অ্যাট রেস্ট আছে কিন্তু কনজেশন নেই, দ্যাট মিনস কার্ডিয়াক ইন্ডেক্স ইজ রিডিউসড but PCWP is intact. In case of low output or systemic hypoperfusion and pulmonary congestion, both PCWP more than 18 as well as cardiac index less than 2.2. So, from the clinical scenario, with a focused target of clinical examination coupled with the symptomatology as stated by the patient, we can assess the patient of heart failure with heart failure, as well as the severity of heart failure, as well as a subcomponent of the heart failure. The evaluation of heart failure. অর্থাৎ ক্লিনিক্যাল স্টেজ থেকে বেরিয়ে এবার আমরা আর একটু প্রযুক্তিগত দিক থেকে এগিয়ে যাওয়ার চেষ্টা করব আমাদের অ্যাকুরেসি নিয়ে আসার জন্য। সেক্ষেত্রে হার্ট ফেলিওরকে ক্যাটেগরাইজ বা ক্লাসিফাই করার জন্য আমরা 1 থেকে 4 পর্যন্ত 4টে প্যারামিটারকে চুজ করি। নাম্বার 1 হচ্ছে সাবস্ট্রেট, নাম্বার 2 হচ্ছে সিভিয়ারিটি, নাম্বার 3 হচ্ছে অ্যাকুইটি, নাম্বার 4 হচ্ছে ট্রিগার্স। What is substrate? Whether there is a prior history of structural heart disease or a background of chronic heart failure. The substrate can be categorized into two: a prior history of structural heart disease or a background of heart failure. Second, severity, from mild symptoms to cardiogenic shock. Cardiogenic shock একটু আগে মেনশন করা হয়েছে, যেখানে সিস্টেমিক হাইপোপারফিউশন প্লাস কনজেশন দুটো কম্বাইনলি থাকবে এবং PCWP definitely more than 18 as well as cardiac index less than 2.2. And lastly, the acuity means gradual onset or sudden or subacute onset. What is gradual onset? What is acute onset? I will tell you later on. And triggers which may be apparent or may be unknown. জানতেও পারি নাও জানতে পারি। অর্থাৎ সাবস্ট্রেটের মধ্যে থাকছে তিনটে ক্যাটাগরি। একটা নর্মাল হার্ট, হঠাৎ করে দেখছি হার্ট ফেলিওর নিয়ে প্রেজেন্ট করছে। সেকেন্ড ক্যাটাগরি বলেছি স্ট্রাকচারাল হার্ট ডিজিজ। স্ট্রাকচারাল হার্ট ডিজিজ কি? আগের ক্লাসে স্টেজ বি ক্লাসিফিকেশনের সময় খুব ক্লিয়ারলি বলে দেওয়া হয়েছে, কারো মনে আছে কিনা জানি না, সেদিনকার কেউ আজকে আছে কিনা সেটাও আমি মনে করতে পারছি না। সেকেন্ড হচ্ছে স্ট্রাকচারাল হার্ট ডিজিজ, আর থার্ড হচ্ছে এক্সিস্টিং হার্ট ফেলিওর। এক্সিস্টিং হার্ট ফেলিওর ক্যাটাগরি হচ্ছে সি বা ডি। কারণ হার্ট ফেলিওরকে ক্লাসিফাই করা হয় on the basis of staging. Number two, on the basis of the level of ejection fraction previously discussed. Show substrate first point. Number one, normal heart. Number two, structural heart disease. Number three, existing heart failure. Existing heart failure ke categorize kora hoy. Number one, heart failure with reduced ejection fraction, heart failure with mildly reduced ejection fraction, and heart failure with preserved ejection fraction. So what is heart failure with reduced ejection fraction? আগের দিন বলেছিলাম L ejection fraction less than equal to 40%. And what is heart failure with preserved ejection fraction? HFPEF. That means heart failure with preserved ejection fraction. যেখানে ejection fraction more than or equal to 50%. And in between the two, a gray zone. A gray zone is 41 to 50%. অর্থাৎ heart failure, mildly reduced EF, HF, MREF. Then the time course. Time course means অ্যাকুইটি যে কথাটা বলা হয়েছিল, অ্যাকিউট অনসেট, ক্রনিক অনসেট বা গ্র্যাজুয়াল অনসেট। What is acute onset? That means in terms of minutes to hours, minutes to hours. Subacute, days to weeks. কেউ খেয়াল করে দেখেছো কি এখানে ক্রনিক কথাটা মেনশন করা হয়নি? কেন? I am going to discuss the case of acute heart failure management, not chronic heart failure management. So deliberately the terminology chronic is omitted here. So time course, sudden means in terms of minutes or hours, hospital management, common general bed management. And severity, তার location, ICCU বা ICU. Triggers. What are the triggers? Cardiovascular triggers such as atrial fibrillation, acute coronary syndrome, pulmonary thromboembolism, and hypertensive emergency or hypertensive urgency. What is hypertensive emergency? What is hypertensive emergency? নামছি শুনতে পাচ্ছি না। হ্যাঁ, what is resistant hypertension? What is hypertensive urgency? So triggers I have mentioned. Now atrial fibrillation I have mentioned, acute coronary syndrome সেটা পরে আসছি। খুব সম্ভবত আমি একটা ফিজিওলজি ক্লাস দেখছিলাম যেখানে অ্যাকিউট করোনারি সিনড্রোম পড়ানো হচ্ছে। আচ্ছা, পি মানে পালমোনারি থ্রম্বোএম্বোলিজম। তবে এই সাউন্ড যদি চলে ব্যাকগ্রাউন্ডে তাহলে গানটা শোনা যাবে না, ঠিক আছে? যতই খারাপ গান করি না, এত ভালো মিউজিক সিস্টেমের মধ্যে আমি তো আবার ডান্স দেবো না পড়াবো না কি করে বুঝতে পারছি না। ঠিক আছে, হেঁটে গেলাম। দশটা বাজতে চলেছে, ঠিক আছে, আমি উঠে যাই মনে হচ্ছে। আচ্ছা, Atrial fibrillation, acute coronary syndrome, hypertension, and pulmonary thromboembolism. Acute coronary syndrome already discussed, either second year or third year. I have noticed a class. There is a non-cardiovascular triggers like COPD, or chronic obstructive pulmonary disease, or pneumonia, renal insufficiency, as well as COVID entry after 2020, and the dietary indiscretion, medical non-adherence, and last but least unknown. জানি hypertensive emergency এটা ক্লারিফাই করা হলো না. Severe degree of hypertension, usually stage 3 or more, associated with ongoing acute HMOD. What is HMOD? Hypertension mediated organ dysfunction. That may be cardiac, that may be renal, that may be cerebral. So hypertensive emergency means severe hypertension, usually beyond the range of stage 3 hypertension, associated with ongoing acute HMOD. This is hypertensive emergency. যখন হাইপারটেনশন পড়ানো হবে তখন ডিটেলস বলা হবে. এবার প্রসেস সাসপেশন অফ অ্যাকিউট হার্ট ফেলিওর. ফার্স্ট মাথায় রাখতে হবে যে whether cardiogenic shock is present or not, this is the urgent phase. অর্থাৎ পেশেন্ট আসা মাত্রই আমার মাথায় ফার্স্ট কাজ করবে পেশেন্টের কার্ডিওজেনিক শক আছে কি নেই. সুতরাং ফেজকে বলা হচ্ছে আর্জেন্ট ফেজ, আর্জেন্ট সিচুয়েশন, অর্থাৎ প্রেজেন্স আর অ্যাবসেন্স অফ কার্ডিওজেনিক শক ইমিডিয়েট ফ্রম দ্য ভেরি মোমেন্ট অফ মেডিকেল কন্ট্যাক্ট. নো নেই, সমস্যার হাত থেকে বাঁচা গেল. সেকেন্ড স্টেপ রেসপিরেটরি ফেলিওর, নেই, সুবিধাজনক অবস্থায় চলে এলাম. তখন আসছে ইমিডিয়েট ফেজ. ফার্স্ট হচ্ছে আর্জেন্ট, পরটা হচ্ছে ইমিডিয়েট. তারপরে কি করব? ইমিডিয়েট ফেজ মিনস 60 to 120 মিনিটস, অর্থাৎ পেশেন্ট আসা মাত্রই আমাকে দেখে নিতে হবে যে কার্ডিওজেনিক শক অ্যান্ড রেসপিরেটরি ফেলিওর, এই লাইফ থ্রেটেনিং সিচুয়েশন দুটো আছে কিনা. যদি না থাকে তারপরে চলে আসছি ইমিডিয়েট ফেজ, অর্থাৎ ইনিশিয়াল 60 to 120 মিনিটসের মধ্যে. তখন অ্যাসেসমেন্ট হবে অ্যাকিউট ইটিওলজি খুঁজে বের করার. কী কী থাকতে পারে? চ্যাম্প, চ্যাম্পটাকে ঠিকঠাকভাবে সাজানো হয়নি, কারণ চ্যাম্প মিনস সি ফর অ্যাকিউট করোনারি সিনড্রোম, H for hypertensive emergency, already discussed, A for arrhythmia, already discussed, like atrial fibrillation, M for acute mechanical cause, that means mechanical problem in the valve like regurgitation or stenosis, mitral regurgitation, aortic regurgitation, pulmonary regurgitation, or stenosis in the form of mitral, aortic, or tricuspid, or even pulmonic stenosis. And lastly, pulmonary thromboembolism. নেই, ইটিওলজি খুঁজে পাওয়া গেল না. তখন ডায়াগনস্টিক ওয়ার্কআপ ইজ টু কনফার্ম হার্ট ফেলিওর. তখন আমাকে পরীক্ষা নিরীক্ষা এবং ইনভেস্টিগেশনের মধ্যে যেতে হবে যে পেশেন্টের সত্যি হার্ট ফেলিওর ছিল কি. উল্টো দিক থেকে কার্ডিওজেনিক শক আছে, সঙ্গে সঙ্গে সাপোর্ট টু সার্কুলেশন. Support to circulation again classified into two types. One pharmacologic, number two mechanical. Pharmacologic means institution of vasopressor, anatomic support, or diuretic therapy. And mechanical means either coronary revascularization in the form of PTCA or mechanical measures for management of the pulmonary thromboembolism or mechanical measurement বলা ভুল, or mechanical management of valve diseases like severe degree of MR or mitral stenosis. Ventilator support যদি রেসপিরেটরি ফেলিওর থাকে তাহলে ফার্স্ট অফ অল অক্সিজেন, নাম্বার টু হচ্ছে ventilation is a passive ventilation or mechanical ventilation. Passive ventilation CPAP হতে পারে, BiPAP হতে পারে। আছে তখন আইডেন্টিফিকেশন অফ দ্য ইটিওলজি পাওয়া গেছে, ইমিডিয়েট অ্যাটেনশন টু দ্য স্পেসিফিক থেরাপি, অর্থাৎ যে কজগুলোর কথা বলা হয়েছে চ্যাম্পের মধ্যে, অর্থাৎ চ্যাম্প কথার ইচ্ছে করে ইউজ করলাম, চ্যাম্প বলাটা উচিত হয়নি, CHAMP কথা বলা হয়েছে, সেখান থেকে যদি ইটিওলজিক ডায়াগনোসিসে আসা সম্ভব তাহলে স্পেসিফিক থেরাপি ফর ইদার অ্যাকিউট করোনারি সিনড্রোম or hypertension emergency or arrhythmia or mechanical cause or pulmonary embolism should be instituted. তারপরে ফলো আপ ডিটেলস ইত্যাদি ইত্যাদি। আগে যেটা বললাম ওটাকে আরবার একটু ছোট্ট করে সামারাইজ ফর্মে বলে নিচ্ছি। এতক্ষণ যেটা দেখার চেষ্টা করলাম যে একটা ডেফিনেটিভ ডায়াগনোসিস অফ এইচএফ আসার আগে আমাদের যেটা করতে হবে একটা হচ্ছে ইমার্জেন্সি ট্রিটমেন্ট ফর দ্য লাইফ থ্রেটেনিং conditions or conditions having life-threatening potentials. যেগুলো আগেই মেনশন করা হয়েছিল, কার্ডিওজেনিক শক বা রেসপিরেটরি ফেলিওর। ফার্স্ট অফ অল ইউ শুড গো ফর সেভিং দ্য লাইফ অফ দ্য পেশেন্ট। ডায়াগনোসিসের দরকার নেই, পেশেন্টকে বাঁচানোর চেষ্টা করো, অর্থাৎ ইমার্জেন্সি থেরাপি ফর দ্য কন্ডিশন having life-threatening potentials. Second, relevant clinical triggers or other requiring specific therapy. Third, risk stratification to triage a patient to gain some form of information that may be incorporated in the decision-making process to launch an opposite therapy. Opposite therapy. And defining the clinical profile based on blood pressure, volume status, and renal function. Already discussed clinically. Suspicion হলো এবার অ্যাকুট ফেলিওর ম্যানেজমেন্ট। এগুলো ভার্চুয়ালি রিপিটেশন করছি যাতে মনে রাখার চেষ্টা করতে পারো, পরপর বলে গেলে কিন্তু মনে রাখার সমস্যাটা কম। মোবাইলটা কিন্তু আমি অ্যাকচুয়ালি অন্য পারপাসে কাজে লাগাই, ঠিক আছে। Diagnosis of acute heart failure, bedside assessment for hemodynamic status, and একজন বলো তো বেডসাইড অ্যাসেসমেন্টে কি কি দেখবো ছোট্ট করে। এখান থেকে এইভাবে বলে গেছে, কিন্তু মনে থাকলে আমি খুশি, কারণ টাইম বড্ড কম। ক্যাপিলারি রিফিল, স্ট্যাটাস অফ দ্য হ্যান্ড, গুড, পালস ভলিউম, পালস প্রেশার, বিপি অ্যাজ ওয়েল এজ কনফার্মেশন অফ দ্য পালস প্রেশার, ঠিক আছে। যেগুলো বলতে না শুনেছে বোঝা যাচ্ছে। হোয়াট ইজ পালস প্রেশার? Diastolic BP plus systolic BP minus diastolic BP divided by 10. Normal values 70 to 100 millimeter of mercury. ঠিক আছে। সেখানে যে প্রেজেন্স অফ কনজেশন, ইয়েস, ওয়েট পেশেন্ট আগে ক্লিয়ার করা হয়েছিল। অ্যাডিকুয়েট পেরিফেরাল পারফিউশন, ইয়েস, ওয়েট এন্ড ওয়ান আগে ক্ল্যারিফাই করে দিয়েছি। ম্যানেজমেন্ট কুইক। ভাস্কুলার ফ্লুইড ডিস্ট্রিবিউশন, অর্থাৎ হাইপারটেনশন প্রিডমিনেট, তাহলে ফার্স্ট ভেসোডাইলেটর, সেকেন্ড ডাইউরেটিক। উল্টোটা কার্ডিয়াক টাইপ অফ ফ্লুইড অ্যাকুমুলেশন, দ্যাট ইজ কনজেশন, তাহলে ফার্স্ট ডাইউরেটিক, দেন ভেসোডাইলেটর, দেন আলট্রাফিল্ট্রেশন। ক্লিয়ার? Adequate peripheral perfusion, yes. Weight and warm, yes. Vascular type, yes. Hypertension plus, yes. First vasodilator, then diuretic. Cardiac accumulation, that means congestion present, first diuretic, then vasodilator, and certain cases ultrafiltration. উল্টো থেকে adequate peripheral hypoperfusion, nay, no, wait and cold. Systolic BP less than 90 millimeter of mercury, no. Vasodilators, diuretics, and consider inotropic support. That means either digoxin, ambrinon, milrinone, etc. or dopamine, dobutamine. Not vasopressor. Vasopressor means norepinephrine, etc. So systolic BP less than 90, no. Vasodilators, diuretics, and consider inotropic support. Yes, the first inotropic support. বিপিটাকে তুলতে হবে, কাজ হলো না, তখন vasopressor agent, norepinephrine, dobutamine, etc. Diuretic, mainly loop diuretics like furosemide, and last হচ্ছে mechanical circulatory support, সেটা পরে আসছে ডিটেলসে। ম্যানেজমেন্ট রাফলি এটাই, আগে অনেক কিছু ঘুরিয়ে ফিরিয়ে বলার চেষ্টা করছিলাম, এগুলো বলা হয়ে গেছে। এবার কথা হচ্ছে হ্যাঁ, ক্রনিক হার্ট ফেলিওর। ক্রনিক হার্ট ফেলিওরের ক্যাটেগরাইজেশন আগে করে দেওয়া হয়েছিল। একটা হচ্ছে ক্যাটেগরাইজেশন অন দ্য বেসিস অফ স্টেজ, আর একটা হচ্ছে ক্যাটেগরাইজেশন অন দ্য বেসিস অফ এলভি ইজেকশন ফ্রাকশন। আগের স্লাইডগুলোতে বলা আছে, আজকে বলতে গেলে আর সম্ভব হবে না। চলে যাচ্ছি স্টেজ এ, সাবজেক্ট ম্যানেজমেন্ট কী হবে। স্টেজ এ মিনস হচ্ছে structural heart disease নেই, কিন্তু risk for structural heart disease or heart failure is high. As for example, hypertension, তাহলে ম্যানেজমেন্ট hypertension. For diabetes mellitus, management of SGLT2 inhibitor, অর্থাৎ পেশেন্টের যদি ডায়াবেটিস মেলাইটাস থাকে এবং হার্ট ফেলিওর থাকে, তাহলে প্রেফার ড্রাগ হচ্ছে সোডিয়াম গ্লুকোজ কো ট্রান্সপোর্টার ইনহিবিটর, টাইপ 2 ইনহিবিটর, লাইক ফ্যান্টাস্টিক, গুড। অ্যান্ড থার্ড হচ্ছে উইথ সিভিডি, অ্যাকর্ডিং টু দ্য ম্যানেজমেন্ট অফ দ্য সিভিডি, কার্ডিওভাস্কুলার ডিজিজ যেগুলো আছে সেগুলো। ফোর্থ হচ্ছে ফার্স্ট রিলেটিভ টু পেশেন্টস, যেটা জেনেটিক বা ইনহেরিটেড কার্ডিওমায়োপ্যাথি আছে, সেখানে জেনেটিক অ্যানালিসিস অফ দ্য ফ্যামিলি করা দরকার আছে। আর যেখানে ডায়াগনোসিস আমরা পুরোপুরি আসতে পারিনি স্টেজ ওয়ানে, সেখানে আমরা পেপটাইড অ্যাসেসমেন্ট, যেটাকে বলা হয় যে কার্ডিয়াক বায়োমার্কার্স, অর্থাৎ বিএনপি বা এনটি প্রো বিএনপি অ্যাসেসমেন্ট করে নেওয়ার চেষ্টা করব। স্টেজ বি, এটাকে বলা হচ্ছে প্রি হার্ট ফেলিওর। এটা কিন্তু একটা রিস্ক ফর হার্ট ফেলিওর, ইজ দ্য স্টেজ বি, প্রি হার্ট ফেলিওর। সেক্ষেত্রে ইজেকশন ফ্রাকশন কিন্তু থাকছে লেস দেন ইকুয়াল টু 40%, তাহলে ফার্স্ট ড্রাগ ACEI, angiotensin converting enzyme inhibitor. Patient with recent MI and LVEF less than 40%, ARB or ACEI. অ্যাকচুয়ালি যদি ARB ইউজ করতে হয়, তাহলে আমাদের ফার্স্ট অপশন ছিল ক্যান্ডিসার্টেন বা ভালসার্টেন, নট লোসার্টেন। ক্যান্ডিসার্টেন বা ভালসার্টেন এই দুটোকে রেকমেন্ড করা হয়, লোসার্টেন বললেও ফেল করানো হবে না, অ্যালাউ করা যাবে। Patients with ejection fraction less than equal to 40%, beta blocker, কার্ডিওসিলেক্টিভ বিটা ব্লকার উইথ তিনটে ক্যাটাগরির মধ্যে পড়ে। ক্যাটাগরি বলা ভুল, তিনটে মেনলি ড্রাগস আছে। ওয়ান কার্ভেডিলাল, নাম্বার টু বিসেপ্রোলাল, নাম্বার থ্রি মেটোপ্রোলাল মেটোপ্রোলাল সাকসিনেট না ফিউমারেট। তারপর আসছে যে ইসকেমিক, আচ্ছা সরি, লেস দেন ইকুয়াল টু 30%, তখন আইসিডি অর্থাৎ ইমপ্লান্টেবল কার্ডিওভার্টার ডিফিব্রিলেটর, যেখানে ইজেকশন ফ্র্যাকশন লেস দেন 30%, সার্ভাইভাল এক্সপেক্টেড মোর দেন 1 year অ্যান্ড 40 days পোস্ট এমআই। অর্থাৎ এই ক্যাটাগরিকে একটু ইলাবোরেট করছি। মায়োকার্ডিয়াল ইনফার্কশন হয়ে গেছে, 40 দিন পার হয়েছে, আশা করা যাচ্ছে পেশেন্ট 1 বছরের বেশি বাঁচবে, এবং ইজেকশন ফ্র্যাকশন 30%-এর নিচে চলে এসছে। সেক্ষেত্রে আমরা ইন্টারনাল কার্ডিওভার্টার ডিফিব্রিলেটর ইউজ করব। মানে এই কস্টলি থেরাপি যে পেশেন্ট 1 বছর বাঁচবে না, তার ক্ষেত্রে বসানো করাটা যুক্তি নেই। আর হচ্ছে নন ইসকেমিক কার্ডিওমায়োপ্যাথি, সেখানে এক কথায় জেনেটিক কাউন্সেলিং অ্যাজ ওয়েল অ্যাজ টেস্টিং। আচ্ছা, এবার আসছি, এটা বলি শেষ করতে হবে। স্টেপ 1, এক্ষেত্রে কি আসছে? স্টেজ এ, স্টেজ বি কমপ্লিট, বাকি থাকলো স্টেজ সি আর ডি। প্রথমে স্টেপ হচ্ছে এস্টাবলিশমেন্ট অফ এ ডায়াগনোসিস অফ হার্ট ফেলিওর উইথ রিডিউসড ইজেকশন ফ্র্যাকশন, অর্থাৎ এইচএফ আর ইএফ, দ্যাট মিনস এলবিইএফ লেস দেন ইকুয়াল টু 40%। LBEF less than 40%, that means stage C, ARNI in NYHA class 2 or 3. NYHA class 2 or 3 আশা করি প্রত্যেকেরই জানা আছে, কারণ কাউকে মোটামুটিভাবে দেখতে পাচ্ছি বড় রকম হাসতে শুরু করেছে বা হেসেই যাচ্ছে। ভালো কথা, হাসি খুব ভালোবাসে, বিশেষ করে ক্লাসে বলা যাবে না কাঁধে হাসি ভালোবাসে, ঠিক আছে। যাই হোক, স্টেজ 2 বা স্টেজ 3 সম্পর্কে আশা করি সম্যক ধারণা আছে, বহুবার ক্লাসে বলা হয়েছে, ক্লিনিক্যাল ক্লাসে বলা হয়েছে। ARNI, দ্যাট ইজ স্যাকুবিট্রিল। বলো, গুড। এক্সাম্পল 1, স্যাকু, গুড 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 গুড, ঠিক। সুতরাং ARNI স্টেজ 2 or 3, ACEI or ARB স্টেজ 2 to 4, অর্থাৎ দুটোর মধ্যে একটা, দুটো কিন্তু দেওয়া যাবে না, কারণ স্যাকুবিট্রিল সিঙ্গলি ইউজ করা হয় না, স্যাকুবিট্রিল ইউজ করা হয় ইন কনজাংশন উইথ তোমার প্রিয় ড্রাগ লোসারটানের সঙ্গে। সুতরাং স্যাকুবিট্রিল অলরেডি ইউজ করা হয় লোসারটানের সঙ্গে, সেই জন্য ACER আর ARB কখনো কম্বাইন করতে যাবে না, বিশেষ করে ডিএম করার আগে পর্যন্ত, এমডি করার পরেও না, আমি তো করি না। আচ্ছা, বিটা ব্লকার কার্ডিওসিলেক্টিভ, মেইনলি কার্ভেডিলাল or bisoprolol. MRA, mineralocorticoid receptor antagonist, that means aldosterone. And inhibitor, SGL2 inhibitor, that means dapagliflozin, according to situation, and diuretics if needed in presence of severe degree of congestion. So establishment of a diagnosis, address congestion and initiate in this particular form. Second step, titrate of doses to target the dosing schedule, as tolerated by the patient as well as by the biochemical profile. LBF একই রকম থাকলো, অর্থাৎ less than equal to 40%. It is persistent HFrEF, that is stage C. Management, আবার ফিরে চলে যাও। Consider this patient scenario. Stage 3 or 4, usually a black subjected ক্ষেত্রে hydral nitrate. That means isosorbide dinitrate plus isolazine. Isolazine, sorry, একটা trade name use করে ফেললাম। Hydralazine. Hydralazine and isosorbide dinitrate. Second হচ্ছে LVEF more than equal to, sorry, less than equal to 35%. সেক্ষেত্রে বলেছিলাম 30%, কারণ তার সার্ভাইভাল রেটটার কথা চিন্তা করে। এক্ষেত্রে 35% ICD। আর থার্ড ক্যাটাগরিটা হচ্ছে স্টেজ 2 to 3 LVF লেস দেন 35%। এটা সবচেয়ে মাথায় রাখতে হবে। এক্ষেত্রে দেখা যাচ্ছে নর্মাল সাইনাস রিদম and QRS duration more than equal to 150 milliseconds with LBB pattern. LBB pattern, that means left. How would you assess the LBB in the surface ECG? Initial septal depolarization, অর্থাৎ loss of Q wave in lead V5 or V6. Usually ventricular activation শুরু হয় by the left bundle branch at the lower end of the interventricular septum. So LBB is characterized by number 1, morphological changes in the form of prolongation of QRS morphology or duration. Number 2, loss of initial septal depolarization, and number 3, secondary STT changes. That depends on either LV hypertrophy is due to volume overload or pressure overload. Pressure overload produces concentric elevate ST segment elevation with tube inversion with blunted apex of T wave. Whether in case of volume overload, ST segment is slightly elevated with convexity upwards, and here is absence of strain is a crucial demarcating point. Now, I see duration 150 milliseconds or more with LBB, CRT device, cardiac resynchronization therapy. এইটুকু মনে রাখলেই চলবে, আন্ডারগ্রাজুয়েট বেশি দরকার নেই। এতে যদি কাজ না হয়, কনসিডার স্পেসিফিক থেরাপি অর স্টেজ ডিতে চলে গেল, অর্থাৎ তার নাম হচ্ছে রিফ্র্যাক্টরি অর ফেলিওর। সেক্ষেত্রে ডেসপারেটলি ঝাঁপিয়ে পড়তে হবে ইন দ্য ফর্ম অফ inotropic support, vasopressor agent, circulatory support, or the conditions responsible for the genesis of chronic heart failure. This is the step 6. The steps are number 1, establishment of diagnosis of HFrEF, addresses congestion, initiate GDMT, guideline mediated medical therapy. Titrate to target dosing schedule. Lastly, consider the clinical scenario on the basis of stage, L ejection fraction, and QRS morphology, and then implement additional therapy, that means additional to GDMD, guideline directed medical therapy, and as well as device therapy. ডিভাইস থেরাপিতে ডিটেলস আসছে না, অনেক ক্ষেত্রে আছে ইন্ট্রাঅ্যাওরটিক বেলুন কাউন্টার পালসেশন। এই যে অনেক খটোমটো শব্দ আছে, আমার মনে হয় না যে থার্ড ইয়ারে পড়াচ্ছি এর বেশি যাওয়া উচিত হবে। আচ্ছা, এইবার কয়েকটা কথা বলে দিই। NYHA class 2 or 3. Normal fire rhythm. Heart rate কিছুতেই কমানো যাচ্ছে না, more than 70 beats per minute. Ivabradine. Good. L1, sorry. NYHA class 2 to 4. LVF less than 45%. Recent IV diuretics অথবা elevated natriuretic peptide level. ভার্লিসিগাট মনে রাখার দরকার নেই, কেন? বিকজ the indication is 2B. 2B মানে হচ্ছে মার্জিনাল বেনিফিট, তোমাদের জানার দরকার নেই, সেইটা প্রজেক্ট করে একটু ভুল করে ফেলেছি, কারণ 2B গুলো আমি ইচ্ছা করে আমি পড়াবো না, কারণ থেরাপির নাম্বার 1 হচ্ছে ক্লাস 1 বা ক্লাস এ বা 1A মানে হচ্ছে ডেফিনেটলি বেনিফিশিয়াল। দুটো ক্যাটাগরি আছে, 2A 2B। 2A বেনিফিশিয়াল মোটামুটিভাবে, 2B কাজ করতেও পারে নাও করতে পারে, আর 3 ডেট্রিমেন্টাল। সুতরাং বেনিফিশিয়াল নয় বা ডেট্রিমেন্টাল এগুলো আলোচনা করছি না, আর টাইমও আমাকে পারমিট করছে না, সেটার দরকার নেই। আচ্ছা, এটা পড়িয়ে দিয়েছিল, আর কি পারবো, এটা মিড রেঞ্জ থেকে একটা ছোট করে বলতে চলে যাচ্ছে। পরের ক্লাস কটায়? এখনই? তা ছেড়ে দিচ্ছি, 1 মিনিট, আমার কাজটা শেষ হয়ে যায়। আচ্ছা, MREFটা আমি পড়াই না, আগেরটা স্লাইডটা ছিল কিন্তু পরিষ্কার করে বলে দিচ্ছি, খেয়াল করেছি কিনা জানি না। REF ছিল, MR মানে হচ্ছে মাইন্ডলি রিডিউসড। কেউ কেউ বলে থাকে যে মিড রেঞ্জ 41 to 49%, diuretics as needed, কনজেশন মানে ডায়াবেটিক্স। ACL2 ইনহিবিটর মানে হচ্ছে ডায়াবেটিস মেলাইটাস, 2A দেওয়া যেতে পারে, মেনশন করছি। 2Bটা পার্থক্য মেনশন করছি না। ACI ARB বা ARNI 2B ভুলে যাও, 2B ভুলে যাও, 2B ভুলে যাও। মেনলি মনে রাখার চেষ্টা করো, ডায়াবেটিক অ্যাজ নিডেড অ্যান্ড ডায়াবেটিস মেলাইটাসের ক্ষেত্রে ACL2 1। থ্যাংক ইউ অল। এবার বড় কোনো কোয়েশ্চেন থাকলে, কোনো কোয়েশ্চেন 5 মিনিটের মধ্যে, কোনো কনফিউশন, কোনো কোয়েশ্চেন এবার কাছে ফেলতে পারো না, তাই কোনো কোয়েশ্চেন
which all of you will require after you pass out. Whether you be a gynecologist, you be a general physician, you must have an idea regarding this. Okay, so I'm going to talk about a topic which has been modified by the medical council. Earlier, when we were students 30 years ago, 40 years ago, it was taught in a different way. Now onwards, due to the medical council, National Medical Council recommendation, we have been modifying this chapter on and on, on and on. And also same way, the MTP Act is also modified. Okay, so today we are going to talk about, quickly I'll give you an idea regarding the Act and this thing. Hey, this is not writing. It লিখছে। Can you see what I'm writing? Now, today we are going to talk about a topic which is abortion. Now, what is abortion? Can anyone tell me what is abortion? Have you heard of abortion? Have you read about it? Tell me. Bolo. Define. When you say abortion, you have to define abortion. It's not medical termination of pregnancy. You tell me. Anybody on this side? তো তোর বলা উচিত পড়ছিলি পড়াশোনা বন্ধ করে দিচ্ছি টেল মি sit down relax yes when remember when the question is defined, so you have to use those terms. You have to be very specific. Okay, in case of definition, you have to be very specific because these are government regulated chapters. Government has to regulate this whole system. Everybody cannot teach, or neither they can do an MTP anywhere they feel like. Okay, it's government regulated. So when you have a thing, it's central government or state government, because there's a rules, and you have to, being a doctor, you have to follow the rules regarding this. So can you read that? Can you read that? This side. Medical termination of pregnancy or abortion is defined as termination of pregnancy before 20 weeks. This is a generalized old definition. 20 weeks, termination of pregnancy before, on and from 20 weeks. Whereas the Royal College, RCOG, Royal College of Gynecologists, they define it as how much? 24 weeks. So in their country, where suppose you are in USA or UK, it will be 24 weeks. Whereas in India of late, they have come up to 28 weeks. So 28 weeks till, that means second trimester. Till second trimester, earlier this wasn't there, there are a lot of changes there. Till 28 weeks, you can go for termination, provided they are very strict. Central government rules and the state government rules are very strict. It has to fulfill the criteria of termination. These details are, this is a huge topic. Okay, we have congested the whole thing. All of the things are there in the textbook. I am just touching on the main points. You go back and read the whole chapter textbook, because I have to cover both sides, the legal part and the text, right? So I'll be briefing the whole thing. So this is the definition. When somebody says definition, you have to mention all the things. The old definition is 20 weeks, RCOG says 24 weeks. In India now, we are allowing till 28 weeks, provided it fulfills the rules and regulations of the government, whether you are in central government or in state government. There is a book, MTP Act consent form. Taking the consent is very important regarding termination of pregnancy, because you just cannot terminate a pregnancy unless otherwise it is indicated. There is a consent form of 5-6 pages. In that consent form, you have to state, being a doctor, it is your responsibility, because you are going to destroy a life. You just cannot. Otherwise, that goes into what? IPC, Indian Penal Code, tantamount to what? Tantamount to what? Murder. So you will be in the Indian Penal Code under the case of murder. So that is the reason there is a book, consent form of 4 pages. When you pass out, when you are doing your duties as an intern or house staff, you will be given that book, whether you have to mention that this is the condition of the mother, this is the condition, and the ultrasound findings are this and this, okay, along with the investigating reports, especially the hematological investigation, because you have to prove, supposing that goes into the court, you have to prove that whatever you have done is correct and following the law. I myself have appeared for 3 or 4 times. I was called by the lawyer. I went in Calcutta also, here in Birbhum also. I had to explain, and that was, I was taken up to court after a period of 15 years. I did a case 15 years ago. Remember, you have to keep your documents. Nowadays, it is tech oriented. You have the pen drive, you have the computers. In those days, we didn't have. We had to keep huge papers of whatever cases you do. In my room, there's a huge stock of papers, all cases, operations that I had done. You have to keep records. Because you don't know when you'll be called. The lawyer will send you a warrant and saying that, doctor, you have to appear in the court, so and so time, 10 o'clock, and with your all records. Now, after 15 years, it was unthinkable. Luckily, I had kept those papers, and I straight went to the court and told the judge that this was the condition of the patient. I explained, and she was bleeding. I had to save the life. In view of this, to save the life of this patient, I had to do a termination of pregnancy. Why I had done? Because she was treated outside. This was an illegal pregnancy. She was treated by a co-worker in her village. She came bleeding. She was referred to me. While she was bleeding, she could have died. I had to take up the case. I have the consents. I've showed him. These are the consents of the mother, father, and her village, as people, as witness. I had 2 witnesses. So these are very important, what I'm telling you, because everybody of you will face this sort of situation sometime or the other in your life. So documentation of your case is very important, because you may not be called now. You'll be called after 10 years, 15 years, 20 years. Because you don't know, the legal cases, they go on for a long time. So that is the reason. Now coming to types. Type 1, one side, and the type 2, other side. Type 1, you have spontaneous abortion. Type 2, you have threatened abortion. Now what is spontaneous? That she has just conceived. Okay, the patient has conceived, and all of a sudden she goes early in the morning in the washroom and says, doctor, she calls up saying that, doctor, I'm in an emergency situation, I'm bleeding, and I feel my products of conception has been thrown out and is lying in the floor of the washroom. These conditions we face number of times. I myself have faced number of times, middle of the night, early morning, 4 o'clock, phone karte. Doctor, amar obostha khub kharab, ami ki korbo? So you have to guide them. That is certain abortion without any pain, without any complaints. She expels the products of conception. Next is what? Inevitable abortion. So first you have abortion. ঘুম পাচ্ছে তাহলে এটা ঘুমলে কিন্তু বিপদ হয়ে যাবে, তখন দেখবি জেলে আছিস, ঘুমোবি না কিন্তু। So this is, first is spontaneous abortion, second is threatened abortion, third is inevitable abortion. Okay, threatened is you are just having some complaints, little bit of discharge, little bit of pain, but it is still there. You quickly ring up the doctor, doctor comes and manages that situation, that emergency condition, so that the baby doesn't, the products of conception doesn't go out or is not expelled. By beriye jano na jao, we have to keep it as long as possible. Okay? Now, inevitable is, you cannot do anything. It is, the word itself is explainable. It's inevitable. Kichu kora jay na, it's been expelled. Okay? Next is, so you have 1, 2, 3, inevitable, and then is complete. Complete abortion means total products of conception is expelled in toto. In toto means what? With the sac. You can see the beautiful sac along with the fetus inside, lying. Everything along with the placenta, it's expelled. I've seen many cases. So that is complete. And next is blighted ovum. This you will get in short note, blighted ovum. What is blighted ovum? It is defined as a gestational sac which does not have a fetal pool in it. When you do an ultrasound, this is an ultrasound finding, blighted ovum. Clinically, you cannot say. When you do an ultrasound, you will see a gestational sac, maybe 6 weeks, maybe 8 weeks, maybe 10 weeks, but fetal pool will not be there. Okay, so that is called blighted ovum. This you will get as short note. Or you may get it in your viva. Viva where? In the table. When you are appearing for the third prof table, they will give you an instrument set. It has an MTP kit set. You will be having dilators, instruments, this, suction cannulas, and they will ask you pick up the suction cannula. And then the question follows accordingly. You pick up the suction cannula and you say that, well, sir, this is a suction cannula. Where is it used? It is used in medical termination of pregnancy. Why do you use this? Because if you have a defective product of conception or a blighted ovum, you can suck it out. How do you sterilize? How do you use the instruments? Everything is there in the book. Whatever I'm saying, everything is there. You have to just organize it. Next is septic abortion. Second last, septic abortion is very important nowadays. Incidents in our time, 30 years ago, when I was like you, those days, every day we used to get cases of septic abortion. Nowadays, thank God to government and also the media, they keep on informing the mothers that please do not go for the abortion in villages, in unauthorized places, in local co-ops, in whether you do. Earlier they used to do. You get pregnant, you go to the co-ops, they'll just do it there only. Because why? Sterility is not there, instruments are adequate, not there, your anesthesia part is not there, nothing is there, but they just do it. As a result, it goes into sepsis. Then they come to us saying that temperature, bleeding, she is high temperature, bleeding and foul smelling discharge. Why? That goes into a septic abortion, and death rate is to the extent of 90%. Once patient goes into septic abortion, they will die. So when you are dealing with a case of septic abortion, you have to be doubly careful. Why doubly careful? That will come into your headache. Quack will say, I didn't do. मेरा ठीक है साहब, वो डॉक्टर ने किया है, उसको पकड़ो. First thing they will do, and village people will support the quack. This is the history. Village people will support the quack saying that नहीं, वो डॉक्टर साहब यहाँ हमारा गांव का है, वो he is fine. वो डॉक्टर ने कुछ किया है, उसको पकड़ो. Lawyers को बोलता है तो उसको पकड़ो. So you have to keep your documents. In what state you got the patient? Patient was febrile. You have to keep all your vitals in order. Patient has on examination, she had a foul smelling discharge per speculum. Internal examination we did not do. We did an ultrasound. It was whatever maybe the finding products of conception was seen in the uterus, and things were etc. etc. Pus may be there on the adnexal side, collection of pus. So this all picture you have to keep the records. Maybe now, maybe after 20 years. What about your findings? These sort of cases you have to be very, very careful dealing with. Next is, another important thing is recurrent pregnancy loss. This comes into our domain because recurrent pregnancy loss itself is a huge book. Only on one topic, that is recurrent pregnancy loss. This is also a type of abortion, but it has a different view, a different management. different investigation. Why? Nowadays, because of the thank God of the mobile, thank God for the IT sector, thank God for the radiation, so much of mobile, this is the worst thing in life. But we cannot avoid. I myself have ample amount of patients coming with recurrent pregnancy loss. Both husband, wife, working in the IT sector, overnight, students, overnight. এখানে একজন স্টুডেন্ট ছিল earlier. আমি আর নাম বলছি না. She was there. She got married. So much of mobile. She used to say that, well, sir, I have to study. I'm going in for an exam. Okay. And then so much of radiation exposure and the products of conception could not bear that radiation. It was a pregnancy loss. So this mobile, because of constant radiation, you have to be very careful. Why? Because if you have one pregnancy loss, your chance of second pregnancy loss increases. Third pregnancy loss increases. Third pregnancy loss is to the extent of 30 to 40%. So you have to be very careful with the mobile. Especially the low-end mobiles, they are horrible. They destroy you. Diseases like endometriosis, I'll be teaching you afterwards. Diseases like PCOS, it was earlier PCOD, now it's PCOS. Why yes? It's a total syndrome. Okay, these are all being due to the radiation effects of the mobile, and especially the towers you have. Nowadays, government has restricted putting up mobile towers in domestic areas, in college areas, in school areas. You cannot put mobile towers. Yes, there's a solid restriction. Why? Because of this problem of radiation. Radiation is a lot of problem. Now, coming to induced. This side, it was spontaneous, and that other side, type 2, is induced. Why? That is medically been indicated, and we, the doctors, we induce the abortion because there may be cardiological problem, there may be hepatic problem, there may be some diseases, there may be genetical disease, one of the commonest cause of abortion. So in those cases, when we come to know there is a problem, we have to go in for termination. That those patients come straight to us because they know nobody can tackle this. So they come to us. So they'll come to you, doctor, saying, my sister, she has this sort of pregnancy, thalassemia or Down syndrome. Please check if I'm having a baby with Down syndrome or thalassemia. First time she has come, you give the investigations, you give the triple marker, quadruple marker, genetic counseling. She comes to you, it's positive. Then she starts panicking. Doctor, what should I do? If my baby becomes thalassemia, if my baby becomes a Down syndrome, then what am I to do? আমি কি করব? Then you have to explain her, look, don't worry. This, we have to again redo all the investigations to make it confirmed. If you find both the investigations are positive for thalassemia, Down syndrome, then we have to terminate. Explain the whole thing, get a consent written down, both by parents and the patient and the husband, everything documented, go for abortion. Then she will say, well, by next pregnancy, what am I going to do? Well, that's a different thing, will come. First, this situation has to be tackled, then we go into the next situation. So this goes, investigation, management, everything is there. Each types you'll be asked. Details are there in all the books. Okay. You please go through all the details, and then I'll ask you for the questions. Now coming to this. This part is definition. Deliberate termination of pregnancy either by medical or surgical method before the viability of the fetus is called induction of abortion. So this is the actual wording. এই ওয়ার্ডিংটা কখনো তোমরা চেঞ্জ করবে না। কথাটা কোথায় আসছে? বিফোর দ্য ভায়াবিলিটি অফ দ্য ফিটাস। আমি বলেছি ভায়াবিলিটির ডিউরেশনটা কত? 20 weeks, or earlier it was till that 24 and then 28. Okay. This induced abortion may be legal, may be illegal. Okay. In India, abortion was legalized by the Medical Termination Pregnancy Act 71. Then it came into force 1972, revised in 75, modified in 2003. Again it is modified in 2012. So just imagine all the modifications. This is most important. Why? Government of India has first came into force the medical termination of pregnancy in 71. Why? They saw why they came into this. Why the government was bothered? They saw mothers who are dying like this. Lot of mothers in everywhere, whole of India, they were dying. Commonest cause was termination of pregnancy, illegal, illegal. So that is the reason. And then government again modified it 75, 2000, 2002, 2003. Again it has been modified. So therapeutic medical termination to save the life of the mother. This is the therapeutic condition where doctor is allowed to do. Nobody can stop you. Why? Condition of the mother. What are the conditions? Just imagine cardiac disease, glomerulonephritis. You have done medicine. Glomerulonephritis, I hope you know it. Malignant hypertension, cancer, diabetic retinopathy, epilepsy, and so forth. There are ample amount of medical disorders where you have to terminate the baby. Otherwise, you may lose both the mother and the social conditions. Almost the sole indication is unplanned pregnancy and low socioeconomic status, rape and contraceptive failure. So this is the social condition. Unplanned pregnancy. Okay. Socioeconomic status, rape and contraceptive failure. These terms are very important. Why? Legally. Because you have to save yourself. Whatever you do before the court, you have to prove that you don't have anything wrong in what you have done. Okay? Suppose you have a rape case, you have to keep all documents because you will be the doctor. You may be posted in somewhere, you may be posted in Birbhum, you may be posted in Hooghly or Bankura. There you have to keep documented thing because nobody else will be there with you. You will be the alone doctor in charge. And a rape case comes, especially this time. Elections, hot, the weather is very hot outside and inside. Anything can happen. So when the doctors are now doing duties, they are in a very bad state. They have to be very cautious. Doctors are doing duties here, Nanur, Labpur, Bolpur, Birbhum, Purulia, Jhargram, Bednipur. Everybody is doing their duties, but they are doubly cautious. Doubly cautious, why? That nobody should touch you. Not even the politician, nobody else. Why? You know your subject. That is the reason I am saying you have to know your subject thoroughly and you have to be confident what you are doing. Nobody can talk above you. You are the sole master. Okay? So this is the eugenic. This condition is rare. As I was telling you, Downs, hemophilia, teratogens, radiation, rubella. I had seen a case of teratogenics. One of my patients was working in Kolaghat thermal plant. Okay, husband was there, wife later on also got a job. They were both happy that they both husband and wife got in Kolaghat thermal plant. It's a huge thing, government property and highly paid. But God forbid, they were not getting babies. 10 years, nearly 10 years of marriage. They couldn't get an issue. Then, one fine day, I was traveling to Haldia. And somehow, somebody came and said, we had a discussion regarding this pregnancy. somebody called me up. I stopped in Kolaghat on the way to Haldia, and we had a discussion, long 1 hour discussion with their doctors, me, other doctors who were also there, how to solve this problem, why she is not. Then we did a genetic study. Mapping was done. It was very expensive though, and we found that both husband and wife, due to prolonged exposure of chemical radiation, radiation plus chemical in thermal plant and heat, there is a genetic transformation. As a result, they were not being able to get issues. So this sort of working condition, both husband and wife, you have to be very careful. IT sector, thermal plants, okay, chemical fertilizer plants. In those cases where your patients are with, you have to be very cautious dealing with them. Okay. So when a pregnancy can be terminated, continuation of pregnancy could involve serious risk of life, grave injury, physical and mental health. So you have to be very careful. You can injure the patient both physically and mentally. Substantial risk of the child being born with serious physical mental abnormality. That baby born also will be mentally depressed. And you cannot have a baby with mentally depressed, because mentally depressed babies will cause a serious problem to the society. Okay. So you have to be very careful. I have one of those patients here in Bolpur. That baby, they were very poor socioeconomic status. They had delivered a baby. Baby was little psychosomatic disorders. Sometimes the baby becomes schizophrenic. Sometimes they go into MDP. Okay, and their parents are really having problem tackling that baby. Whole family is disturbed. Everybody is disturbed. Locality is disturbed because of that child. So you have to be very careful dealing with these patients. Failure of contraception, of course, is another indication. Who can terminate now? I was telling you that you, the doctors, will be, after passing out, will be getting an initial license. So only a registered medical practitioner can terminate. Means after you pass, you get your registration, then only you can. Possesses a recognized medical qualification defined in the IMC Act 1957. So that your degree has to be qualified, your degree has to be documented by the Indian Medical Council or INMC, and it has to be following all the rules required. Like one person who comes from Bangladesh, okay, or say China, he does an MTP and then goes back, it is not allowed. These sort of things have happened earlier in India. Like for example, Sweden, Netherlands, they don't allow medical termination. Those patients is to fly to Mumbai and with their doctors, they do the termination in Mumbai, and then after staying few days, they go back. I have seen, this also I have seen. They fly from Sweden and Netherlands and countries where medical termination is not allowed. They fly to Mumbai, get their doctors along with the Indian doctor. They'll say, okay, I'll give you some money. Doctor, India, they'll be happy. Are, 1 কোটি টাকা দিল, termination করে ফেরত যাও। কার against হচ্ছে? না Indian doctor against এ। কে করছে? না doctor from Netherlands. So you have to be very careful. কোনো রকম illegal জিনিস you cannot do. কারণ documentation তোমার নামে থাকবে। You will be the person responsible. Documentation has to be done in any hospital in India, and that will be under your name. So you may be motivated. You may be motivated, you may be forced, but to keep your spine straight, your honesty and your dignity, you will not allow this sort of things. টাকাটা কি আছে? No problem. You will earn 1 crore for a doctor. ঠিক আছে, হয়ে যাবে। But this sort of illegal things you will not involve into, because after 10 years, 20 years, you'll be maybe called by the court. You don't know. Okay, কারণ ওদের গভর্নমেন্ট, ওদের কনসুলেট, Netherlands consulate will say this lady went to India and got it done. What will you do? Then they'll track the whole thing. Who took it? Where did they done? Which hospital it was done? Everything will be tracked down. Then you will be in problem. So you have to be very careful. See, he have his or her name entered in the SMR register. Okay, have experience in such training in GA. Whoever does an MTP has to be experienced and has to do a house job in gynae. It's very important. Where can pregnancy be? In a hospital maintained by the government. Remember, sterility is very important so that you do not go for what I was talking about, septic abortion. Not in villages, in schools, in their own clinics, in where sterility is not mentioned. In places approved by the government, district level, DLC constituted by the government. Only consent of the woman, married, unmarried or single, is required. Husband's consent is not required. Kichu kichu khetre. This is very important. Woman's consent or wife's consent is very important. But in case of congenital defects or other conditions in thalassemias, Down syndrome, husband and wife and a witness is very important. You have to take into account all these factors because you have to save yourself. So in case of minor, this is a very common complication in Bengal. Below 18 years, mentally ill person, consent of guardian is required. A guardian has to give the consent that, well, this along with the father, mother and a witness. Termination is permitted 20 weeks. 3 to 5 members including a chairperson. 1 member should be a gynecologist. So if you have critical cases for termination, government has says that 2 doctors' consent is very much important along with an anesthetist. Okay. Other members should be local, medical profession, NGO, Panchayat Raj, and this is. Because of this, these local politicians come in because they know that Panchayat Raj or a member from the Panchayat has to be informed in cases of, in villages where you are dealing with a critical case. And this is the place where politicians come in. Okay. So at least 1 member should be a woman in that committee. DLC district level appointed by the government, responsible person. These are all rules and regulations of the Act. A place can be approved for termination up to 12 weeks. It has following. Gynecological examination has to be there. Supposing you are doing it in a small nursing home in Bolpur, it must have the following criteria. Gynecological examination, labor table, resuscitation, sterilization equipment. This is very important. You must have a resuscitation instrument, means you must have an anesthesia machine. A Boyle's machine in your OT has to be there. You may need anesthesia, you may need resuscitation of the patient, where you must have full oxygen supply, nitrous, etc. Okay? So your site or your OT has to be well equipped. Then only you can do. Resuscitation, sterilization is important. Drugs and parenteral fluids must be there in case of emergency. Any drug you may require. May it be syntocinon, may it be what you call Degdan, betamethasone, dexamethasone, or maybe dopamine, or maybe other emergency drugs. Parenteral fluids must be there and blood. Backup facilities to treatment shock. In case patient goes into shock, you must have a backup facility. So remember, these are very important topic. Facilities of transportation. You have done it in the nursing home, small nursing home in COD, and you cannot manage. Patient is bleeding. Patient has gone into shock. You have to save the mother. Transfer to the nearest medical college. Maybe Rampurhat, maybe Santiniketan, maybe Bardhaman Medical College. So transportation is very important. Requirements. A place can be approved for termination up to 20 weeks if it has an operation table. If it has, first of all, it has to have a license from the government. Then it has to have an OT with a good operation table. anesthesia machine and instruments, resuscitation, drugs, etc. These are all I've already told. Experience and training up to 20 weeks. This is very important. This will be asked. Up to 20 weeks. At least 1 year of experience in gynae and obstetrics in any hospital. You must have 6 months of house staff training. This is for you. 6 months of HS training in OBG and diploma or a degree in GNO. You can do up to 20 weeks. If you are a consultant, if you are a senior gynecologist, you can do anything because you have the authorized degree and the experience. I can do 28, 30 weeks. Nobody will question me because I have gained the experience over 40 years. So then only government allows me. Otherwise, they will not allow you. Up to 12 weeks, assisted registered medical practitioner and who has done 25 cases. Minimum 25 cases has been done by, suppose you become a doctor, you are posted in the nearby hospital in the Birbhum or Rampurhat and you have done 30 cases of MTP. You can do it. Government will legalize this thing. Okay. Abortion is legal only when it fulfills the following. And registered medical practitioner, this RMP is not QOC. This is registered medical practitioner with the authorized degree. You people, when you pass out, you'll be having an authorized degree. It is performed to an approved place and other requirements, consent, opinion has to be taken into a provider. Will get the protective cover, legislation. These are all legal part. So you have to be very careful. Methods of termination. If you have first trimester till below 12 weeks, vacuum aspiration or electric vacuum aspiration. This will be both for your table, short case or a long case. So this you have to be very careful where things will take you to. So you have to follow it. Medical method of termination, mifepristone or mifepristone, misoprostol. These are prostaglandins. You are already read in pharmacology prostaglandins, PG1, PGE1, PGE2 alpha, F2 alpha, different categories of prostaglandins. And you know how prostaglandin is synthesized in the body as well as externally. Can anyone tell me prostaglandin from where it is synthesized? কোথা থেকে আসে বলতো? বল বলতে পারছিস না? Tell me. Pathway. How the prostaglandin in the body is synthesized? Because this is prostaglandin is an important hormone. Okay, and it controls a lot of things from eye, from your heart, everywhere it is synthesized in the uterus, in the genitourinary system. Lot of places prostaglandin is synthesized. Okay, this came into when we were students. That time it was discovered by a senior doctor who was dedicated. His name was Dr. Abdul Karim. He was working for 20 years on prostaglandin. Later on, he came to know in the 70s or something it came that this could be utilized in medical profession. After 20 years of research, we found out that prostaglandin is a very important drug, very good drug, but you have to be very cautious. Those things which are good are also harmful. Fast food is very tasty, but at the same time it is harmful. খেতে খুব মজা লাগে momos, rolls, chili chicken, chow mein, dangerous things. All these foods are dangerous to your life, both for boys and girls. Why? One of the causes has been proved of PCOS is MSG. What is MSG? MSG? तुम बोलो महेंद्र सिंह धोनी? नहीं, but it is not. MSGs बोलतो? 93. Monosodium glutamate. Come on, everybody knows it. MSG is monosodium, and what is that? Nothing but Ajinomoto. And Ajinomoto is one of the commonest cause of PCOS, of infertility, of all the problems that you are having in this adolescent period causes Ajinomoto. And every food, Chinese food, every fast food, they will put MSG. Even if you tell them that you please do not put Ajinomoto, they will put it. Chow means, they will put it. Chili chickens, they will put it. MSG is detrimental. So please be careful with MSG. Next is methotrexate, misoprostol, tamoxifen, misoprostol. These are all 1 chapters. I'll take, if I keep talking, I'll be taking days and days, because methotrexate is a very good drug. It is used worldwide in varieties of diseases. Okay? Misoprostol is also same thing. This is a prostaglandin which is not only used in medical termination, it is used in a lot of places. It is used in cardiology, it is used in nephrology. You'll be coming to know. As you go, you'll be coming to know. Tamoxifen is another important drug. Very important drug. Here, this drug, tamoxifen, is used very commonly in breast cancer. Tamoxifen. Okay, this is also used in MTP. So you may be asked, what are the other indications? Surgical, dilatation and curettage. Uterine contents are evacuated through a cannula. Why I said? In the table you'll be given that cannula and they'll ask you, why did you do it? What was the indication? How do you sterilize it? So remember, up to 12 weeks, 98 to 99% is effective. Time taken 5 to 15 minutes. If you are an expert, it takes 5 to 15 minutes to complete the job. Today morning I did it. That patient, her mother had a cardiological problem. He was having fibrillation. Some medicine doctor referred to me. The doctor, this lady is having fibrillation and she is carrying 10 weeks. What to do? I said, nothing, terminate. Because fibrillation with the pregnancy, as it goes, it will increase and goes into heart failure. Mother will die. You have to save the mother, terminate immediately. Today morning only I did. Documented the whole thing, got the ECGs, 2 ECGs documented by the physician and by my anesthetist, got the mother into the OT, did the 5 minutes job if you are an expert. And she is fine. Now she'll go home. So you have to be very, very careful of what sort of patients you are dealing with. Follow-up visit is mandatory, needs local anesthesia. Earlier, they never used to use anesthesia. But nowadays, government is saying that anesthesia is must. Okay. Post-op pain, hospital stay few hours, 1 or 2 hours, patient stays in the hospital and then goes. Risk of fetal malformation if pregnancy continues, cost effective, male partner not allowed, tissue samples may be required. Endometrial biopsy or the tissue may be required for your safety. Patient will say, no, I don't require biopsy. But for your safety, you may have to do biopsy of the endometrium as well as the products of conception. Acceptability, low levels of pain medication done in OPD settings, women wake up, noiseless. Medical methods. What are the medical methods of termination? Up to 9 weeks you can do, where the products of conception is very small. You can use prostaglandins, misoprostol, mifepristone alone or in combination, then she aborts. But you have to be very careful. Why? We have seen patient goes into bleeding. I have seen patient goes into rupture. Like I was doing first year PGT. I'll tell you a short story. First year I was doing, just entered into MD, first year. I was on sole मुर्गी बना दिया तो अकेला नाइट ड्यूटी ठीक है भाई करने पड़ेगा no way out. Night duty I was doing, believe me, alone, and that too in Pune. Total first day of my entry, and at 2 o'clock at night, patient comes. Patient baby was 30 weeks baby. Somebody in the local village put a misoprostol inside. 600 milligram of misoprostol was put into the vagina. Why? She was complaining of pain, and that doctor in the village had the idea that this will cure her and pain will be. She landed up, I touched her, Sister called me. She said, doctor, some problem. She's gasping. I ran down, saw. Immediately, first thing I did, put a channel, arrange for blood. I was guessing what had happened. That I called my boss. Sir, you need to come down. There's a dire emergency. We have to save the mother. And it was a ruptured uterus. 30 weeks, ruptured uterus. Patient was bleeding both vaginally and abdominal. We opened the abdomen. My boss came quickly. He drove down. The doctors have to drive down. Not a luxury, but an emergency. Took his car, because that time at 2 o'clock you will not get a driver. Neither your own driver, how much you give, they will say, no, bhai, maaf kar do. Nahi chahiye. So you have to drive down. And he came. We opened the abdomen quickly. By the time he came, I've taken the patient to OT, channels both hands, blood arranged, everything arranged. Because I knew all these things have to be done. I did everything. We opened up. I was the first assistant. My boss was the surgeon. Whole abdomen, you won't believe, was filled with blood. And ruptured happened. It touched the uterine vein. Lower segment and touched the uterine vein. Then we tackled, closed the vein, ligated the artery. We got a hysterectomy done. Why? This could not be repaired. Initially, you have to preserve the uterus. But when you have shattered uterus, we have to go for a hysterectomy, cesarean hysterectomy. We took out the baby did not survive. We did a cesarean hysterectomy to save the life of the, we tried to preserve the uterus, but we could not. It was shattered. Stitches were not this thing. Time was running out because anesthetist was saying, 5 minutes, sir, 5 minutes, you please, close. We don't have time. Patient will die on table. So quickly we did a 5 minutes, we did a cesarean hysterectomy and came out. Patient survived. Everything was fine. Next morning when I came for rounds, mother was fine. So this sort of emergencies you will have to tackle yourself and you have to be confident. Okay? Follow-up visit is important. Risk of cervical injuries. These are all textbook talks. I don't know. Acceptability, non-invasive, more private, no hospital stay. Dilatation of curettage. These are all operative procedures. Okay. The operative procedures that you do, how do dilatation, it is given in the books. Dhorbe, ki kore dhorbe, ki korbe, kothay speculum debe, ki kore dilated. What are the dilators used? Hocking-Amler and Hager's. Why it is? Number is there. 2 by 3, 3 by 4, 5 by 6, everything is there in the books. If you have any problem, please come and ask me. Anytime. 98% effective. Yes, dilatation is curettage. 98% you are successful and only 2% of cases you may go for perforation. Complication is perforation. There you have to be, doctor has to be sure that I have perforated. You have to inform the patient party and you have to go for repair. Open the abdomen and repair. That also we have done. Okay. Follow-up visit is mandatory. Needs. Sedation, GI anesthesia is very important nowadays because of the legal part. Risk of fetal anomalies, cost more due to hospital stay. Involvement of the more male partner, tissue sampling is very important. Okay. Now, suction evacuation, all these things are there. I'm not going into the details. Second trimester. Second trimester means after 12 weeks till onwards. Okay. Here is also very important. It includes induction by abortion, cervical dilatation. Here, cervical dilatation is very important. You have to gently, slowly dilate the cervix. This is the very important part because if you don't dilate, you won't be able to take out the product of conception because it has grown. It has become big. Baby has become big. Earlier, now how do you dilate? There are many methods of dilatation. Ithacridine, lactate, mifepristone, misoprostol. These were earlier used. Mifepristone, misoprostol nowadays used for cervical dilatation. Ithacridine, lactate was used. Surgical methods. Now, suppose you have dilated, baby is not coming out. 3 days are over. Parents are on your head. What should I do? How many days you are going to take? Nobody knows. It depends on slow dilatation and evacuation because the contraction has to set in. Uterine contraction will set in and it will expel the baby. For that case, If you don't, if you can't, 3 days, 4 days are offered, you know your time is running out, then you have to go explain them for surgery. What are the surgeries? Hysterectomy, hysterectomy. Nowadays, hysterectomy is not done. Just if you can manage, you have to manage it through the vagina. In very rare cases, hysterectomy is allowed. Hysterectomy only you have complications. Otherwise, you don't go for an hysterectomy. Medical methods here: how to dilate, mifepristone, prostaglandins, oxytocin. Okay, oxytocin. Ethacridine lactate is becoming outdated. Earlier in our students' time, we used this ethacridine lactate. Who recommends the combined use of mifepristone, misoprostol as the safest method? WHO says for second trimester. Combination, you have to have detailed knowledge regarding prostaglandins, because prostaglandins are very good drug. Simultaneously, they are very dangerous drug, and you have to take a history of the patient. WHO recommends the use of D&E as the preferred method over hysterectomy. Nowadays, hysterectomy is reduced. We don't go. We go in for a medical termination from below. Okay. Recovery period is important. Opportunity to provide women with information, education, including you have to support them, mental support. As your doctor, you have to support both her parents as well as her husband and the wife. It's your duty to support them. Support for doctors. Doctor, no, don't worry. It will come. Don't worry. I'm there. So for your side, you have to support them. Things can happen. Accidents can happen. But it's your duty to support them. Every woman after second trimester abortion should be scheduled for a following checkup. All these, you must call your patients for a checkup. Following up of the patient is very, very important, both legally and for your side also. Because in the court of judge, they'll ask you, did you follow the patient after doing it? If you say no, then you are in trouble. If you say, well, 2 weekly, I followed up my patient for three times, then fine, no problem. Thank you.